Let's talk about chronic pain, specifically that persistent, debilitating pain in the back and spine that affects so many people. It's one of the biggest health problems on the planet. But you know what? For decades, the way we've even talked about it has been completely wrong. Today, we're going to dive into a massive shift happening in medicine, one that's creating a whole new code for understanding and treating pain. To get a sense of just how big this is, look at this number: 619 million. That's how many people worldwide were dealing with chronic low back pain back in 2020. It's the single leading cause of disability on Earth. So yeah, this isn't some small niche problem. This is a huge part of the human experience. And for a long, long time, if you were one of the millions who had surgery that didn't fix your pain, you got slapped with this label: failed back surgery syndrome. And this quote here really says it all. The keywords are misleading and pejorative, which is just a fancy way of saying judgmental. Think about that. It was a diagnosis that didn't explain, it blamed. So, let's really get into it. Why was this failure label so damaging? What was so fundamentally broken about calling it failed back surgery syndrome? Well, here are the core issues. First off, it was way too narrow. It only talked about people who'd already had an operation. What about everyone else? Second, it points a finger, right? It implies the surgeon failed, the surgery failed, maybe even the patient failed. But the biggest problem, the real deal breaker, is that it told you absolutely nothing about why the person was still in pain. It was a dead end. So obviously, something had to change. And in 2021, a group of international experts did just that. They proposed a whole new way of thinking about this, and it all starts with a new name. And you can see the difference right here. We're moving from a judgmental term to a neutral one: persistent spinal pain syndrome, or PSPS. It's not just for post-op patients anymore. It's for everyone with this kind of chronic pain. And instead of focusing on a single event, the surgery, it describes what's actually happening, an ongoing condition. It's about looking at the whole person, not just their surgical scar. And the new system, this PSPS, is actually really simple to understand. There are just two types. Type 1 is for people with chronic spinal pain who have never had surgery for it. And Type 2 is for those who have a history of spinal surgery. And just like that, you've brought millions of people who were ignored by the old definition under this new, much more useful umbrella. But look, changing the name is great, but that's just scratching the surface. The real revolution here, the thing that changes everything, is a fundamental shift in focus from where the pain is to why it's happening. This right here is the main event. For so many years, a diagnosis was all about anatomy. A doctor would look at an MRI, point to a disc, and say, "There's your problem." But that's often not the full story. The new thinking says, hold on, we have to understand the pain mechanism. In other words, what's causing the pain signal? Is it the tissue, the nerves, or is it the brain itself? To make this super clear, let's use an analogy. Think of your pain system as a fire alarm. The first pain mechanism is called nociceptive pain. This is the straightforward stuff, actual tissue damage from something like arthritis or a muscle tear. In our analogy, the fire alarm is working perfectly. There's a real fire, and the alarm is telling you about it. Okay, second type, neuropathic pain. This is different. This is when the nerves themselves, the body's wiring, are damaged or malfunctioning. So in our analogy, there is no fire. The problem is faulty wiring in the alarm system, and it's just going off on its own. This is that classic burning, shooting pain you hear about with something like sciatica. And the third one, nociplastic pain, is maybe the most fascinating. In this case, there's no fire, and the wiring isn't necessarily broken, but the entire alarm system has become hypersensitive. It's turned up to 11. The central nervous system is now amplifying pain signals, making you hurt even when there's no clear injury. The system itself has changed. Okay, so we've got these different pain mechanisms. That's great in theory, but how does a doctor actually put this into practice? How do they use this information? Well, that's where this new tool comes in. It's called the PAM scale, and you really should think of it as a whole new language for doctors. It's a way for a surgeon, a pain specialist, and a physical therapist to all talk about the same patient and be on the exact same page, using precise, meaningful terms. So here's how they build the code. It's a simple four-step process. P is for PSPS type. Are they a type 1 or type 2? A is for anatomy. Where exactly is the pain? M is for mechanism. The big one. Why does it hurt? Is it nociceptive, neuropathic? And C is for certainty. How confident is the clinician in their diagnosis? And this is where it all clicks into place. Look at that first example. The old diagnosis, lumbar facet-mediated pain, is fine, I guess, but its PAMS code, P1A5M3C1, tells you a whole story. It's a type 1 patient, pain is in the lower back, the mechanism is nociceptive tissue pain, and the doctor is certain. It's just a night and day difference in precision. So what's the point of all this? A fancy new code. Who cares, right? Well, it matters a lot, because a more precise diagnosis leads directly to smarter, safer, and just plain better treatments.
At the end of the day, this is about getting the right therapy to the right patient. When you actually understand the pain mechanism, you can stop just throwing treatments to the problem to see what sticks. This could mean way fewer unnecessary surgeries. It means we can lean into more targeted options, like neuromodulation. The whole goal is just better, longer-lasting results for patients.
Here's a perfect example. Say you have a patient who's already had surgery. That makes them a PSPS type 2. And their pain is clearly neuropathic. It's that faulty wiring. The old approach might have been, well, let's do another surgery to fix the anatomy. But the new code screams, the problem is the wiring. So maybe instead of another high-risk surgery, a treatment like spinal cord stimulation, which directly targets that nerve signaling, is the much smarter choice. So, if you remember one thing from this whole explainer, let it be this. This entire shift, this revolution, it's about moving past a simple map of the body. The future of treating chronic pain is all about understanding the complex mechanisms of how we hurt, not just pointing to where on a scan.
By creating a more precise language, by focusing on the why behind the pain, this whole new system offers a ton of hope for more personalized, more effective care. And that leaves us with a really powerful question to think about. Could this new code truly revolutionize how we treat one of the oldest and most stubborn problems in all of medicine?